Good morning, everyone. It's such an honor to be here. Thank you, President Britt, for the kind invitation to come. I've not attended the meeting previously, and I've only been living in the South now for a little over 4 years, and it's great to see such a huge venue with diverse institution representatives and people attending. And so when asked to speak at such a big venue, I often don't speak on endocrine surgery because I realize as an endocrine surgeon, only endocrine surgeons are really interested in what we do. And so I struggled to come up with a topic, but I thought that I should speak about something that I'm passionate about. And when it comes to endocrine surgery, I'm passionate about the parathyroid gland. So I want to talk a little bit about my perspective on parathyroid disease, and hopefully for the young people in the audience to think about parathyroid disease as you encounter patients. So something I'm very passionate about is our faculty. This is our faculty at UAB, and I've had the honor of being the chair there for almost 5 years. And I love my job, and I love this group, so I'm glad to be able to share a picture of them with you this morning. So the parathyroid gland was the last gland discovered in man, and it was discovered by Sir Richard Owen in an Indian rhinoceros, shown here. So the funny thing about this discovery is that now the rhinoceros is associated with the parathyroid gland forever. And interestingly, if you really know if a surgeon is passionate about the parathyroid gland, if they like rhinoceroses. It seems silly. So if you go to my office, you see these all around my office. And I think if you look around many endocrine surgeons' offices, you'll see there is a rhinoceros present to signify their passion about parathyroid disease. So the most common disorder of the parathyroid glands is primary hyperparathyroidism, which accounts for probably more than 100,000 new cases each year in the United States. About 1% of the general population has it. It's much more common in elderly patients and females, and it's actually the most common endocrine disorder after diabetes and thyroid disease. And for the students and residents in the audience, this is an important fact because it is the #1 cause of hypercalcemia in both the outpatient and inpatient setting. And so when I lecture to our medical students monthly, I inform them if you see someone with hypercalcemia, your first thought should be hyperparathyroidism. So the question is, are patients with primary hyperparathyroidism appropriately diagnosed? So we asked this question at our own institution shortly before I got there, or just after I got there. And so what we were able to do is go into the medical record, the electronic medical record, and see if we were doing well with the diagnosis. So between 2011, 2015, there were almost 700,000 patients in the electronic medical record at UAB. And so we went through and checked how many patients had a serum calcium level done. And I guess it's not surprising, almost half the people seen at UAB had a serum calcium level drawn. And of those 300,000, about 10,000 of them had a calcium level that was abnormal on any laboratory test done, whether it be the inpatient and the outpatient. So then obviously the next question comes, I've just told you the #1 cause of hypercalcemia is hyperparathyroidism. So logically, the next test should be getting a PTH. So what percentage of patients at UAB had a PTH checked who had an elevated calcium? Unfortunately, only 31%, which means we have missed so many people with the diagnosis of hyperparathyroidism at our own institution, and I expect it happens all across the country. So I think we need to do better in this, and we've been trying to find a way to do better at UAB. And why does it matter if we make the diagnosis? Because I think that there are many benefits to treat patients with primary hyperparathyroidism, many of which you are familiar with already, is that there's great data to support all of these statements. We know that parathyroidectomy improves your renal function, bone density. It's a huge cause of osteoporosis. Many patients have neuropsychiatric symptoms such as fatigue, which gets better. But the ones highlighted in green, you may not know, but there is robust data to support that if you take a patient with hyperparathyroidism and treat them, and importantly, the only curative therapy is surgery, there is a reduced suicidal thoughts and risk of suicide. It improves insomnia and sleep patterns. It relieves heartburn. It improves your quality of life markedly, and I'll show you a little bit of data on that. But perhaps, and most importantly, and overlooked by our medical colleagues a lot of times, is that if you have someone with hyperparathyroidism and you don't treat them, they have a marked incidence, a risk of dying from heart attack or stroke. So if you do a parathyroidectomy, you can prolong their survival. And you reduce, and this is mostly by reducing the number of cardiovascular incidents. And there have been great cost studies which show that actually it's more cost effective to treat primary hyperparathyroidism than to observe it or monitor it. So what I'd like to share with you in the next 15 or 20 minutes is where I think we are with parathyroid disease today and how we should treat it. And I'll admit right now this is just my personal opinion, but hopefully a lot of it backed by either published data, which I'll share with you, or just the experience of taking care of many patients. So I think today what we see with hyperparathyroidism and why we're missing the disease a lot is that we are missing patients with what we call mild hyperparathyroidism. So what is mild hyperparathyroidism? So the diagnosis of primary hyperparathyroidism is made quite easily. You have patients usually present with an elevated calcium and an elevated PTH, and these are the normal levels at our institution. So it would be a slam dunk diagnosis. You see patient number 1 in your clinic, the calcium's up, the PTH is up. This patient definitely has primary hyperparathyroidism. And this was what we would call sort of the classic, the type of hyperparathyroidism that anyone can recognize. However, we often see patients like this with an elevated calcium, but the PTH is in the normal range. So this patient definitely has hyperparathyroidism because if your calcium is elevated, if you do not have hyperparathyroidism, if you have another cause of hypercalcemia, such as malignancy, that PTH should be suppressed, virtually zero. So this gets missed all the time. And furthermore, sometimes a patient will have only one elevated calcium, and their calcium will be abnormal, and that will be the key to know that they have hyperparathyroidism, but you have to, people don't follow up at that one abnormal calcium. Sometimes they get another one, and they believe the normal one instead of the abnormal one. This is another common scenario where the calcium is in the normal range, but the PTH is elevated. And in this scenario, it's important to rule out causes of secondary hyperparathyroidism, such as low vitamin D, but most of the time, this patient will also have primary hyperparathyroidism and needs to be worked up. And so typically, patient number 2 and patient number 3 would be classified in the mild category. They have mild primary hyperparathyroidism because their laboratories are just barely abnormal. But I'll suggest to you in the next few slides is that their disease isn't really mild. So we did a study almost, I guess, a decade ago when I was a faculty member at the University of Wisconsin looking at these patients with mild disease because we were operating on more and more of them and really asked the question, what are we trying to do by operating on someone who had just mild laboratory abnormalities? And so what we did is we used a standard SF-36 health survey, which measures quality of life. And for those of you who have utilized it, the survey is broken into different components. There's 8 individual components and 2 composite scores for both physical and mental well-being. And what we did is we administered this to 174 patients with primary hyperparathyroidism a week before surgery, a week after surgery, and 1 year after surgery to measure their quality of life. And this is the only data slide I'll show on the slide, and I'll walk you through this. So this is a graph which shows the improvement or changes in quality of life after 1 year. And these are the different categories, the 8 categories on the SF-36, and the composite physical score and the composite mental score. And the dark green bars represent those patients with classic hyperparathyroidism with both elevated calcium and PTH. And so what you can see on this graph, all patients basically report an improvement of quality of life, which is what we'd expected and had been described before. But what was really surprising, and I think this is the first literature to show this, if you look at the patients with mild disease in the light green bars, they have an improvement, and their improvement is even more than patients with classic disease. This is something that we didn't expect. But now, over a decade of taking care of these patients, it turns out that these patients with mild disease often are even more symptomatic than those with classic disease, which intrinsically doesn't really make sense, right? How could someone with, laboratory values who are not that abnormal have more symptoms? But I see this all the day. In fact, now my practice, the majority of patients have mild disease, is who I see, because not everyone is willing to operate on them, and they seek us out. And this is just one of my patients, and I can post it because she posted it on social media, and actually gave permission to use it. But basically, this is a young woman who had mild hyperparathyroidism, who was disabled, who was at home not working because of the number of symptoms she had. And she'd had surgical intervention, was failed, but we finally found her ectopic gland and cured her, and she was able to return to work, return to a normal life, and actually participate actively on social media. So I hope that I've convinced you that we should consider taking care of these patients with mild disease. So if we make that decision, how do we approach the operation? So we heard a talk about ambulatory parathyroid surgery today, and so the parathyroid surgery today, I would define it, at least in my practice and the practices that I've been affiliated with, is almost all outpatient. Almost all surgery is done in an ambulatory center, and if patients do have some comorbidities which prevent that, we operate them on the main hospital and still discharge them the same day. So for, I would say, 95 to 98% are done as an outpatient. The operation is generally 1 hour or less. And the only restriction we put on our patients is tell them no heavy lifting or exercise for 1 week. After a week, you can do anything. The vast majority of our patients do not take any narcotics, just take Tylenol and ibuprofen. And so it is really now a different operation than perhaps what it was done in the past. And I've had the pleasure of taking care of almost 2,400 patients with this disease. And just my thinking on this has evolved over the time period. And so we have had an explosion of patients seeking to be treated for endocrine disease, especially hyperparathyroidism. This represents our endocrine surgery experience at UAB over the last decade. And you can see there has been a great uptick in the number of patients undergoing surgery at our institution. And that is primarily driven by patients seeking treatment for hyperparathyroidism, or us recognizing the disease in a whole bunch of patients who were potentially ignored previously, working them up, and then operating on them. So if you're going to operate, what is the best approach for patients? And I think that our thinking on this has evolved. And in the 90s, what became very, very popular is what I term unilateral, targeted, minimally invasive, focused, or concise parathyroidectomy. And the concept is that since most patients with hyperparathyroidism have a single adenoma as a cause, why not image that gland, resect it, and use an adjunct such as intraoperative PTH to show that's the only bad gland, and therefore make your operation much smaller with a smaller incision. And I think with the advent of this became the technique of choice in the late 90s and up until today. And previously, our gold standard operation was what we called a bilateral exploration, where instead of necessarily doing imaging, we would just visualize all 4 parathyroid glands, identify the abnormal ones, take them out, and then be done. And this technique was very successful prior to our advent of minimally invasive surgery. And I would suggest for the trainees in the audience, as an examiner for the American Board of Surgery, I'm shocked that many residents can't describe this operation anymore. So for those of you taking your board, I would basically tell you you need to know how to do this operation and describe it. But importantly, this operation doesn't depend on you doing any imaging, just good surgeon judgment. So the question is, if you have these two choices, either we are minimally invasive or our bilateral approach, which one is the best one? And I would say that I utilize both procedures, and it's very dependent on the individual patient that I'm seeing. So for example, if you have a patient who has a very high calcium in the PTH, they're more likely to have a single gland, and perhaps those with comorbidities too. And so in those patients, I may get an imaging study, and if it's positive, do a focused approach using intraoperative PTH. But in clearly patients who are going to have multiple glands that are abnormal, such as a patient with multiple endocrine neoplasia, or patients with mild hyperparathyroidism tend to have multiple abnormal glands, I do a bilateral approach, and I don't do any imaging. And I find today in my patient population, more and more patients are actually choosing to have the bilateral approach. They come to my clinic and say, you know, I want you to remove my abnormal parathyroids, but I want you to look at all four of them and to assess them because I need your eyes on them. So if they tell me that, I say, that's fine. We won't get any imaging, and we'll just proceed directly to surgery. So that brings up my next question. Do we really need to do imaging to take care of patients with primary hyperparathyroidism? So those of us many in the audience are familiar with the different techniques we can utilize for parathyroid imaging. The most common, I would probably guess, is ultrasound, because many surgeons want to do ultrasound not only to potentially find the parathyroid gland that's abnormal, but also to assess the thyroid gland. Probably what a lot of people are familiar with and utilize readily is the sestamibi scan, which basically is an injection nuclear medicine test that we inject sestamibi, which goes to glands that have high number of mitochondria, such as abnormal parathyroid glands. It also goes to the thyroid gland, but you can see if you take a picture here, the thyroid gland may hide the parathyroid gland, but if you let it wash out, here's the abnormal parathyroid gland. Or probably the latest person or scan on the block is our 4D CT scan, which is basically another word for a high definition CT scan with IV contrast. And here you can see clearly there's a parathyroid adenoma. So certainly these imaging studies are available. They're all not perfect. I would say they're readily utilized. And so these are our options. So, you know, what am I saying that we don't need to utilize them? Well, so we recently put together our experience in looking at, do these imaging studies really improve the outcomes for patients? And so when we looked at our series here of patients with primary hyperparathyroidism, certainly the vast majority had undergone imaging, shown here, almost 1,900. And that's because in our practice, what happens is that someone diagnosis of hyperparathyroidism is made, maybe the primary care doctor, the endocrinologist, someone else orders the imaging study and then sends them to us. But in our case, we have a lot of patients who we've told the endocrinologist, don't order any imaging, let us see them first, and we've not ordered imaging. And so this is 178 patients, it's clearly smaller than the imaging, but this is a practice that we've begun to do recently. But if you look at the outcomes, there's a high rate of surgical success in both series. If you do imaging, you tend to do more unilateral approaches if you find a single gland. So certainly the difference is if you do more imaging, you can get unilateral operation in more patients. But if you look at the outcomes with regard to permanent recurrent laryngeal nerve injury, hypocalcemia, recurrence rate, they're all the same. So basically, when we look at the outcomes, there is no difference in patients who have had imaging versus non-imaging. So those of you who do this type of operation are probably asking, well, this guy's crazy. He's telling us not to use imaging studies. What about the thyroid? We need to do a thyroid ultrasound, right? There's going to be, studies have shown like 25% of patients with hyperparathyroidism have thyroid pathology. especially thyroid nodule, you're going to miss that thyroid cancer, and you're going to do a disservice to that patient if you don't do an ultrasound. And so when I speak and say I don't do an ultrasound, many people accuse me of being this, just sticking my head in the sand and ignoring the thyroid disease. But argue, the ostrich must do this for a reason, right? And does okay. So then I said, well, do we really need to know about all this thyroid disease, and do we really need to treat it? And so there wasn't a good way to answer that, right? Because we don't know what happens if you don't intervene. But I decided, let's do a study. And so we published this study a few years ago, and at the time I was at Wisconsin, and none of my partners wanted to be on the study because they all did ultrasound. So, but we had a unique opportunity to study a set of patients, because when I arrived at Wisconsin, my senior partner, who had just retired, had been doing parathyroid surgery without ultrasound for years. And so what we did is I had the good opportunity to look at his cohort, 222 patients who did not have an ultrasound of their thyroid, but just went directly to parathyroid surgery with a sestamibi scan. And we had followed them for 15 to 25 years. So then asked, so of all these patients who we ignored the thyroid, how many presented with thyroid disease later on? So it was interesting, of the 222 patients, 13 patients presented for a thyroid evaluation with an ultrasound, of which 7 underwent a fine needle aspiration, and only 1 thyroid cancer was diagnosed. And that was a micropapillary thyroid cancer, which probably didn't need to even be treated. But importantly, not a single one of these patients had unnecessary thyroid surgery. Because we know if you do an ultrasound and a biopsy, and the biopsy is suspicious, you will end up taking the thyroid out, and sometimes that thyroid doesn't need to come out. So as I mentioned, I do not routinely order any imaging studies for patients who are referred to me for surgery for primary hyperparathyroidism. Now, what I do utilize for my operation is radio-guided parathyroidectomy. And so in radio-guided parathyroidectomy, we inject the patient with 10 millicuries of sestamibi here in the pre-op holding area. And we actually mark them so the nurses know that it's been administered. We go to the operating room and we use a gamma probe. We set a background count on the thyroid gland. And then sometimes if we have a hard time localizing the parathyroid gland, we can use it to scan and locate the parathyroid gland. This is an example of what the counts look like. It's very different than sentinel node. The background count is only 191 on the thyroid, and the count on the parathyroid gland is just a little bit higher, 341 here. So these counts are much lower than what you see in sentinel node for breast and melanoma, and that's a lot of people have a hard time using it for parathyroid because they expect to see super high counts. But I think the gamma probe is very important so we can measure the ex vivo activity and know that for sure what we have taken out is parathyroid, or if we have question, we can biopsy it and count it on the probe. And there's a 20% rule that's been described in literature that if you take the radioactive count of what you've taken out and divide it by the background count on the thyroid isthmus, if it's greater than 20%, it's definitely abnormal parathyroid tissue. And therefore, I never do frozen section when I do parathyroid surgery. We just utilize the probe. It can help you in situations like this where you have a patient who has a trach here, you're trying to figure out where to make your incision. It can help you localize the incision. It's very effective in even patients who have negative sestamibi scans. We published this series early on, so we use it on all patients undergoing parathyroid surgery. And here's an example of a school teacher I took care of where the parathyroid gland was here below the angle of the jaw, which we could localize with the probe and take out. We also utilize the probe to find parathyroid glands which are within the thyroid gland. So sometimes it's said about 4 to 5% of all parathyroid adenomas are within the thyroid. And we don't do a thyroid resection. We just enucleate the parathyroid gland using the probe so the patients can save thyroid tissue and minimize the risk of being on thyroid hormone. And this is just an example of a patient with parathyroid cancer who I operated on for the 7th time, and we could use the probe to dig through scar tissue and dig out the tumor. And we utilize this technique for mediastinal parathyroids. This is our initial case report when I was at Wisconsin with our thoracic surgeons, where we use the probe to find this is a thoracic, a mediastinal parathyroid gland. And this is just a picture from in the operating room. Here's a lung that's collapsed here. Our thoracic surgeon is telling me that's the parathyroid gland, but she's wrong. It's actually down here. And we just used the gamma probe, and here it's shining to pinpoint the location and take it out. So it's great technology utilizing that rare case of a mediastinal. And it's also useful for patients with secondary and tertiary hyperparathyroidism. So how do we make our surgery cost efficient? Well, I have mentioned omitting imaging can reduce the cost. Doing the operation as an outpatient can minimize the cost. But there are other ways in this day where we're looking to make care more efficient and cost effective. And this is a project that my partner, Vanessa Lindemann, did in looking at how to improve efficiency and looking at what we do in the operating room. And this is looking at the surgical instruments that we actually use for operations on the parathyroid gland and the thyroid. And so I don't need to tell you all that healthcare costs are dramatically rising, and there are many studies showing that our ORs are not as efficient as they could be. And so what we did is we looked at UAB at the trays we were utilizing for thyroid and parathyroid surgery, because inefficient trays can contribute to OR inefficiency. So this was the tray that they were preparing for all our cases of thyroid and parathyroid surgery. I mean, there's some instruments that I don't even know that are on this. And the time they take to prepare this, I said, wow, do we really need all of this? And so what Vanessa did with the team is they basically took all the head and neck trays by the OR staff, looked at what was utilized, and decided, let's move to a new streamlined tray and get out all the unnecessary instruments that we never use, put them back in the stock. And we looked at the time that they need to set up the tray weight, number of instruments, and recognizing that it costs about 50 cents to process each instrument, roughly, in an operating room. So this was our original head and neck tray, which had almost 100 instruments on it. And it took them 8 minutes to set it up. It weighed 27 pounds, and the reprocessing cost was $50. And then there was a turnover time cost of transition. We moved it to a tray of only 36 instruments, which only took 3 minutes to set up, only weighed 10 pounds. The reprocessing cost was markedly reduced, and the turnover time cost. So we effectively saved the operating room a lot of money just by changing the tray. And so this was the original tray, and this is the new one. Very streamlined. Now we have available for surgeons peel packs of some instruments that may not be on the tray that they need, but honestly, since we moved to this, I can't even remember the last time I asked for something else that wasn't on the tray. And so we think this increases OR efficiency and cost effectiveness. This was picked up actually by this publication, Same Day Surgery, which they highlighted Vanessa and her work to streamline surgical trays. And basically this started a movement across our whole operating room to streamline all the trays for all the different specialties. So lastly, I just want to end with a story about chasing the cure. Hopefully that everyone in the room will recognize we need to treat hyperparathyroidism. And chasing the cure comes from, you may not have heard, this is a relatively new show that Ann Curry leads. And I will just play a clip about the show so you know a little bit about it.
Thank you for visiting the Chasing the Cure website. We're launching a groundbreaking new project to help people with undiagnosed illnesses. Help us solve these medical cases. If you or someone you know has been struggling for some time with an illness that has gone undiagnosed, we invite you to submit your story and case file. You can participate by becoming part of our community. Write in, post, and give any perspectives that might help people find answers. Together, we're chasing the cure.
So I'm sitting in my office at 4:30 one afternoon, and I get a text from our media people and say, hey, Ann Curry wants you to see a patient. And I said, what? And he goes, well, they've identified you as a physician who can take care of this unknown disease. And I said, well, can I know more about it? And they go, no, you just have to agree to see the patient, and they want you to send this message to the patient. And I said, okay. So an hour later, I'm in our studio taping what I'm about to show here. reading from a script, not knowing anything about the patient except that they may have an endocrine disorder. And so I'll play you that clip, which was on TV.
A malabsorption issue. Okay, that's number one. Genome sequencing, we just heard from Dr. Koo talking about looking for possible
This is a
underlying
patient with $1
genetic
million
causes.
workup.
And then you heard from your doctor physical therapy to help with your arthritis, right? That's a smart move. And then we also have a connection with an endocrinologist. We have a top subspecialist in that field. His name is Dr. Herb Chen. He's the chairman of the Department of Surgery at the University of Alabama at Birmingham, one of our collaborators. And he sent us this message for you, Sean. Take a listen.
Hey, Sean. It's Dr. Herb Chen here at the University of Alabama at Birmingham Hospital. I've become familiar with your story, and I'm excited to invite you here to the O'Neill Comprehensive Cancer Center at UAB to rule out any metabolic or hormonal reasons for your weight loss. We are really looking forward to meeting you. See you soon.
Wow, that's just great.
Well, you smart. I think that's a yes. I mean, yes,
Yeah,
double thumbs.
definitely.
Okay,
Two thumbs up.
I love his enthusiasm.
and that's in your home state.
It is,
It's a
it
top
is.
doctor
It is.
in Alabama,
Yes.
and then also, what about the genome sequencing? Would you
Yes,
like us to
yes,
pick you up for that?
definitely,
Okay, so we've got a
definitely.
yes, definitely on all of that. Well, that's fantastic.
So, I was a little worried, like, what am I going to do? So I assembled a team. But interestingly, so I got his record, and this is, Sean, I'm sure they chose me because he lives in Alabama. It was convenient. So he had been suffering, he said, weight loss and fatigue and bone pain. But the weight loss, when we looked at his records, his weight was basically the same during this whole time period. But he had, like I said, had $1 million workup, oncologist. They thought he had cancer. And so I got his record, and he had a single elevated calcium. And I was talking to my good friend John Olson on the phone about this, and he goes, wow. I said, this is incredible, that they're gonna think I'm a genius because they've seen all these experts across the country, and he really has hyperparathyroidism. So we brought the guy in. Indeed, he had hyperparathyroidism. I did his operation, and here's his post on Facebook saying that I did a subtotal parathyroidectomy at a parathyroid hyperplasia, and he, like many patients I take care of, when he woke up, said his pain was gone immediately when he woke up. And so another person disabled on national TV, he's back to work, he's a pesticide person. And so just remarkable on how, again, primary hyperparathyroidism, a straightforward diagnosis, was missed by people on TV and across the country. So I hope I've shed some light on about the state of art of parathyroid disease. I'd be glad to take any questions. Thank you.